Hello, everyone, and welcome to the How Can We Help Our Patients in Pain exercise webinar. This webinar is part of our Return to Work, Stay at Work series, and we're glad to have you here with us today. My name is Tanya Hyde, and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability, and this webinar is made possible through the support of the Community Grants Program through the BC government, as well as through donations and memberships. As I mentioned, my name is Tanya, and I'll be moderating the session and handling the Q&A session today. And our speaker is Dr. Catherine Harmon. Dr. Harmon is an associate professor at Dalhousie University. In addition to her physiotherapy degree, she completed an MSc in anatomy and neuroscience and a PhD in psychology and neuroscience. In her research programs, she uses both qualitative and quantitative methods and has a focus on improving pain-related therapeutic interactions between patients and healthcare providers. Currently, she's exploring how the healthcare provider can be effective in facilitating patient self-management in low back pain. Thank you very much for being with us, Dr. Harmon, and I will hand it over to you now.
Thank you, Tanya. The first question I have for you is I do not see the right-hand panel that I did when we were practicing before, so I don't know if that comes up at all or I don't get to see it.
There should be a small, at the top right of your screen, orange arrow. If you click that, no, you don't have nothing, huh?
No.
Well, you don't really need it, because I'll be monitoring everything else, so it should be fine.
All right, good. So good afternoon. I'm speaking from Halifax, and I don't know where you all are, but welcome to this webinar. As Tanya mentioned, I'm doing some research in the area of getting better patient outcomes and really focusing on the healthcare provider quite a bit. From my vantage point, I'm a physiotherapist, but mainly an academic physiotherapist. I don't treat patients right now, but I'm doing research in the area. I have heard and I've experienced that one of the biggest frustrations that practitioners have is that their patients don't do the exercises that they prescribe to them. So one of the messages of today's presentation is really about kind of having a conversation about this particular problem. But on the other side of the story, rehabilitation and becoming active or returning to activity after an accident or injury is very hard work. So I know that from both sides of the relationship as a physiotherapist, but also as a long patient and a competitive athlete with chronic injuries. So it's very hard work to go back to zero or to have a setback and start again. And so we need to think about both sides of the relationship as we try to get the best outcomes for our patients. When I was a student, the foundational roots of physiotherapy were still very visible, and they are in the military, if you don't know that. Kind of a regimented approach was really some of our basic early approaches to exercise. And I still remember as a student going to a center, and all the patients were in the gym at the same time, and there was a physiotherapist sort of barking instructions out to them, kind of like the picture I have on the screen. So that's why I like this cartoon, because it does remind me of the sort of tension between what we really want for our patients and the challenge that they have. So the bottom of the cartoon says, okay, everyone jump up and touch the ceiling 100 times with the palms of your hands, which of course is an impossible task. And if you can't read it backwards on the storefront, it says exercise and futility. So this is what I want to just chat with you about. As I said, I'm doing a little bit of research in the area, so I'm going to give you some views I have on this particular challenge. Just wanted to disclose there's no commercial interest in the work that I'm presenting. So this is a slide that kind of just gives a bit of the context of pain in the world. We know that 1 in 5 Canadians suffer from chronic pain. That's what this sort of picture at the top is trying to depict. We know that chronic pain costs a great deal, and when we compare to different conditions, cancer, heart disease, HIV, all combined, chronic pain outweighs the cost to Canadians and North America as well. And when we sort of dial down a little bit more into what kind of costs it represents, direct health care, more than $6 billion a year, indirect related job loss, sick days, and a study I like to refer to in that regard was done a few years ago in the United States, where they found that about half of the workforce is at work in pain. About half of the workforce is at work in pain at some point in their day. And this raises questions of productivity and so-called absenteeism, which are particularly important for return to work issues. Now, the global burden of disease is a study that's done periodically, and the 2010 report ranked low back pain as the leading cause of years lost due to disability. And so what they do is they measure the years that could have been healthy, the years that a person could have had a healthy life that were instead spent in states of less than full health. And they've ranked low back pain as the leading cause of this type of loss. So it's a serious problem for us in the workplace and globally. And if we just look at low back pain more specifically, despite years of research into rehabilitation for people with chronic low back pain, clinical outcomes remain relatively poor. And with the cost of low back pain, as I mentioned, by any standard, low back pain is a substantial burden to society. And as our population ages, with the higher incidence of chronic disease, there's a shift towards patient self-management. And that's essentially one of my messages today. Recently, in clinical practice guidelines released for physiotherapy practice, they included the use of patient counseling and education to address psychosocial barriers to rehabilitation, including when adopting exercise programs. So we are seeing a rise of understanding that there's more to it than just asking someone to do an exercise program. Although low back pain has been widely considered a self-limiting problem with a favorable prognosis, this is only when taking into account the present episode at a discrete point in time. When looking over the course of an individual's lifetime, with the exception of significant trauma, it's difficult to determine whether a particular episode of low back pain is new, independent, or is a recurrence of prior injury or incidents. So despite the notion that it's self-limiting, low back pain, unfortunately, does not resolve permanently for many sufferers. And one of the things that we follow, with interest for the last number of years is an attempt to classify low back pain. And one of the more recent efforts by Dunn and colleagues has looked at 4 different clusters or ways of presenting low back pain over a period of 12 months. So just again, for trying to put a context to all of this, and my point, is that recurrence is a pretty strong problem or an issue. The 4 classes that they came up with were persistent mild, where patients have stable or low levels of pain but continue to function; recovering, where they have an episode of mild pain and quickly progress to no pain. So those 2 are people who are just going to get through the episode and do pretty well. Cluster 3 was termed severe chronic, where patients consistently had high levels of pain and their lives were detrimentally affected in many respects. And the 4th was fluctuating. So that we now have this more of a clear recognition that there is this recurrency, and that varied from mild to high levels. The latter 2 groups typically had pain for longer than 3 years prior to the study, and this just gives an example, another illustration of how heterogeneous the low back pain population is. 2 more points on this. One is that irrespective of classification. Doesn't matter what kind. Several reviews of the literature found that after 1 year, 41 to 66% of patients have not recovered full function, and between 73 and 80% will still be experiencing pain, with 10 to 20% of the patients developing persistent disabling pain. So in my view, that it's important that we continue to look, even though our record hasn't been that great, we need to keep looking at rehabilitation. So a little bit about exercise and low back pain. For chronic low back pain specifically, the American College of Physicians and also the American Pain Society found exercise to be one of the few interventions that shows effectiveness. Exercise prescription appears to be the most cost-effective, evidence-based intervention for chronic low back pain, and currently there's really no significant evidence that one form of exercise is more effective than others. Regardless of the type of exercise used for chronic low back pain, it's well established that adherence to the exercise program is the key to success. I tell my students, you know, we can't exercise for them, right? However, has consistently been found that only a small percentage of individuals with low back pain adhere to prescribed exercise programs. So we have a problem here. A little bit more about this notion. We can go to qualitative research to help us understand, you know, what is it? What is going on? So there were two recent meta-ethnographic reviews. So this is a review of qualitative research. And the two reviews actually came to very similar conclusions when they looked at studies that were focused at asking patients what they perceived as barriers to adopting exercise. So it was found that participants were often critical or wary of the vague diagnosis of non-specific low back pain or back pain. In fact, there were quotes that said something like, you know, you can't give me a really clear diagnosis, but you can prescribe very specific exercise, and I don't buy that. It doesn't make sense to me when you present those things to me. And this diagnostic dilemma has often led to poor exercise compliance. It appeared that many participants were not content with the diagnosis and could not, you know, because it couldn't point to any specific pain structure, they just had a lack of understanding of why a specific exercise program would work for them. The second theme that emerged from these two studies is that the fear of pain or re-injury consistently surfaced as a significant barrier to activities of daily living and therapeutic exercise, which I'm sure you have all encountered as well. In addition, the lack of patient knowledge regarding the benefits of exercise also appeared to be a barrier. And then the third theme, which I put on the screen here, emerged as important, that the patients often relied heavily on healthcare providers for guidance and desired continuous face-to-face support. And when that was not present, adherence to prescribed exercise programs was poor. So these two reviews concluded that there are modifiable factors. These are things that we can address, and that patients are more likely to engage in programs that are designed with consideration of their preferences, circumstances, fitness levels, and exercise experience, rather than perhaps more standard approach to exercise prescription. Evidence from the quantitative side of our literature also is quite interesting, providing other insights into adherence. One review looked at factors that predicted poor levels, and the other what might facilitate adherence, so traditionally barriers and facilitators. They found that no single strategy showed any clear advantage comparing one to another, but comprehensive interventions that combined cognitive, behavioral, and affective components were more effective at improving adherence than single interventions. And they named these things here on my slide elements of importance. The existing level, considering the existing levels of activity by the patient, demonstration of adherence during the treatment program, psychological factors such as self-efficacy, depression, and anxiety, the presence or level of pain during exercise, and the use of behavior change motivational strategies in the program were all predictors of improved exercise adherence. Physiotherapists have become involved in studies and practices where a cognitive behavioral approach is employed, and others are studying approaches such as motivational interviewing as ways of formally incorporating psychological techniques into their practice. We recently published 2 papers in Physiotherapy Canada examining the behavior change techniques that physiotherapists use in their practice and a particular approach that is a combination of patient self-management and behavior change techniques, all with the aim of supporting patient self-efficacy. One of the great criticisms that we receive from physiotherapists is there's just not enough time to add these psychological techniques to practice. However, our research shows that we can draw on the strengths of the cognitive behavioral approaches and facilitate behavior change in our patients during our brief treatment contact time. And one of the things that affords us this opportunity is the way that we practice. We teach and then we observe our patients as they practice new activities and exercises. This is a prime time to use these psychological techniques to motivate the adoption and also to learn for long-term exercise adherence. So let's just think about that for a minute. Psychologists have often engaged in conversation about exercise with their patients in pain. Thank you very much. But I believe that patients don't generally go to psychologists thinking about exercise prescription. In fact, I think that it is a big challenge for physiotherapists too, that patients do not often come to us thinking that they are going to be increasing the amount of exercise that they do. Imagine that you have had low back pain for 3 months or more. You finally get a first meeting to see a physiotherapist, and the expectation is that they're going to find out what's wrong and fix it. You're uncertain because everything you've tried so far has not worked. You can't deal with the idea of the pain getting any worse. You're on leave from work, let's say, your spouse is doing extra shifts to cover your bills. You need to get back to work and are willing to do almost anything, but are not really sure how physiotherapy is going to help you. You enter a small cubicle and meet the physiotherapist for the first time. What do you think is going on in the patient's head? What do you think is going on in the physiotherapist's head? Well, I can tell you what's going on likely in the physiotherapist's head. Physiotherapists are motivated by a desire to help their patients, and our exercise specialists, we know that there are incredible benefits to exercise. In fact, this is a quote that I've had on my door for years. You can see it's sort of torn in the corner. I've also been keeping track of the benefits of exercise. And it's sort of a funny thing. I have like piles of paper stuffed in 4 or 5 boxes, which are all now like strong evidence. There is strong evidence that exercise has a positive impact on all kinds of aspects of our lives. And so I just put that up in sort of the Olympic rings to make the point that it's a very broad-reaching impact. And we can use this knowledge to help motivate our patients. But in the therapeutic exercise world, we've also developed quite an expertise in more prescriptive exercise. And there are many ways to take our patients through this sort of progression. And I've kind of tried to draw it as a progression starting from the bottom right and then going up to exercise and general sport. So we use in the context of pain and chronic pain, we progress our patients. We start from where they're at. We consider the sensitized nervous system, neuroplasticity, and we use intentional, repeated, novel movement. We guide our patient to relearn motor patterns and become confident that they can do it without triggering their pain. That's what rehabilitation is. There's also a growing body of evidence for therapeutic therapeutic exercise, not just this Olympic rings, but in fact some very specific exercises. So I have two tables here. They come from a scoping review that I did a few years ago, and they simply reflect the type of exercise and the focus of the exercise where significant benefit has been demonstrated. And the outcomes that we looked at were pain and disability. So just to explain the table, so on the left column, all the data that went into this one is from about non-specific low back pain. So if there was an exercise such as yoga, now I didn't have a real focus, the focus of the exercise is yoga, but then after general exercise, there was either focus on strength or endurance or flexibility, an exercise program delivered in a group or individual, and the focus was endurance, spinal stabilization, manual therapy. That's the way that the data was put together. And all of these studies provide significant evidence to support the effectiveness of these types of exercise on pain and disability outcomes. And then this table is about other conditions, not low back pain, but other chronic conditions. So neck pain, musculoskeletal pain was one grouping, hip or knee pain, and so on. So we have this growing evidence that specific therapeutic exercise has an effect. So what is it about having access to an effective intervention that patients do not adopt or stick with it? And the question is about engagement, right? So I have another poll. There it is. I'd like to take a minute to get you to participate, and I want you to type in the questions box one word that represents what you think is necessary to get a patient in pain engaged to participate in an exercise program, and then Tanya will read the results out loud for everyone to hear.
All right, let's see. We have hope, education, motivation, results, beneficial, belief, interest, trust, buy-in, rapport, relief, meaningful, group involvement, responsibility, determination.
Wow.
Understanding, encouragement, goal-oriented, connection, confidence, success, helpful, awareness, empowerment, enjoyment, validation, compassion/empathy, pacing, non-judgmental, supportive, doable, and that kind of wraps. I think that's all.
That's incredible. That is fantastic. Oh my gosh. Like it was, I mean, I couldn't keep up with it all. Trying to write them all down. That's awesome. So you get the flavor of the day. That's for sure. Thank you for engaging in this is the idea. So this is an old cartoon now. I'm sure you've seen it before. What fits into your busy schedule better? I can't remember what the real line was, but I just changed it to exercising 1 hour a day, kind of playing on that whole 23.5 hours a day video that you likely all saw. The message of what I'm trying to package up together today is simplistic maybe, but if we focus on adoption, behavior adoption, or behavior change instead of exercise prescription and instruction, we may be able to engage our patients in a way that addresses some of these identified barriers to adoption and adherence. So a simple approach may not be the best or the most effective, but it's one way to think about it, and maybe it'll work with a subset of your patients, is to think about three things. Oops. Here. Expectation, importance, and confidence. And I had some of that came out in my poll. Thank you very much for that. So whether a client engages in an exercise program likely depends on what they're expecting at the beginning, how important the outcome is to them, and their confidence in doing the work. And if we understand and think about this, while we're delivering the knowledge, the education that so many of you do, the coaching that we have to offer, perhaps there will be a better pickup in practice. So here's some data to support this. And I've been actually reading quite a bit about expectancy theory, and if there are questions about it later, I'm happy to talk about it. But this table is some sort of a bit of a review I did maybe about a year ago to try to explore a little bit about this phenomenon of expectation. And their findings about the treatment expectations. So what the person expects out of the treatment that they're getting has a very strong and significantly strong influence on the outcome that they're going to have. So in this table, the three studies that are above the middle black line there, thin black line, are systematic reviews. So this is the analysis of other papers, trying to find data that is comparable and gathering it together to see what the strength of the effect is. And those studies below that black line are randomized control trials. And so what we see, and it's all in the 2000s, so it's all relatively recent. We see that study author on the far left, and then the kind of population that was studied or reported on in the paper. So musculoskeletal pain, a range of health conditions, the second one, acute low back pain, acute and subacute low back pain, and then chronic low back pain. But the findings is what is really quite remarkable, and I've tried to distill it down just to give you the flavor of it. So in the three systematic reviews, the top ones, the first one says recovery expectations predict health outcomes. So what the person expects will be the outcome predicts what the outcome will be, right? Positive recovery expectations associated with successful health outcomes. So if they come in with a positive expectation that they're going to actually get better, whoops, guess what happens? It's more likely that they're going to get better. And then the third one, negative expectations. This was done in a return to work study. Negative expectations predicted more limited activity, longer duration of sick leave. And then the studies below were were a little narrower because they were randomized controlled studies. And so on acute pain, expectations was associated with functional improvement, higher expectations associated with lower disability. And it goes on. It's a very strong finding, and I find it really quite interesting. So I've said in the beginning how to engage a patient. Think about what their expectations are. See if there is something that you can influence on their expectations. Second one is importance. We also need to consider how important it is to the patient to achieve the treatment outcomes. The importance that a patient assigns to activity is associated with the perceived need of the outcome. And if that outcome is valued by the patient, then there's a strong motivation to engage in the activity. And we as clinicians can use the knowledge that we've gained through our rapport, which was one of the words that came out in that poll, to discover the health benefit that is valued by the patient. And we have a huge advantage with exercise, with that Olympic rings and all the evidence that is really supportive of therapeutic exercise as well. There are many health benefits. So we just need to match up, find what the patient values to what we have a knowledge about. And once there's a perceived need by the patient, once the importance of the health benefit of exercise is discovered, then the last step is to help the patient learn that they can do it. And that third one is confidence. I think I heard confidence in that. Self-efficacy is another word that points to this. And in fact, the expectation literature brings in self-efficacy as well. So we have this expectation of self-efficacy, believe it or not. There's a whole factor of that where the person will do better if they believe that they will be able to do it, right? It makes sense. So exercise programs intentionally designed to enhance patient self-efficacy will build on this important psychological factor. High exercise self-efficacy is a facilitator to exercise adoption in patients with chronic non-specific low back pain. And a recent synthesis of systematic reviews, so that's called a meta-analysis, identified self-efficacy as one of the most consistent predictors of physical activity in adults. There is a reported reciprocal relationship between exercise, behavior, and self-efficacy. So participation in exercise tends to increase, sorry, lost my line here, tends to increase self-efficacy. So participation increases one's belief that we can do it, and then that reinforces exercise behavior and continued exercise participation. We can do it, and we continue to do it, right? So ways that we can find to support the development and enhancement of self-efficacy are really powerful. And some of them that have been suggested: set up sufficient time and support to try exercises, supervise the exercise adoption, help the patient understand why they're doing it, let them practice. And group exercise programs, again, that came out in the poll, are one of the best ways to do this. Okay. I mentioned at the beginning that we've done some research in this area, and we were looking at behavior change techniques as one of our, or a couple of our studies. These techniques, these behavior change techniques, are used extensively in the cognitive behavioral approaches aimed at helping patients to adopt new behaviors. Behavior change techniques are discrete psychological interventions, just little psychological interventions, and examples are mental rehearsal of a successful performance, or maybe self-talk, or identifying, thinking about health consequences of behaviors, becoming aware of those things. These are observable and replicable. That's what behavior change techniques are, and they're designed to alter or redirect processes that regulate behavior. Now recently, Mishi et al. In 2013 created a new taxonomy of behavior change techniques in psychology. But when we did our study, we were basing it on their original work, Abraham and Mishi, and we created a list of operational definitions of 29 physiotherapy behavior change techniques that included things like relaxation training and modeling and graded exposure and goal setting. And we categorized them also as cognitive and behavioral and motivational. And what was interesting in our research, we found that over 70% of our list overlapped with the psychologist's list. So we went on further to observe physiotherapists using these techniques in their physiotherapy practice. So our aim in this work was to create a language with operational definitions and about the psychological techniques that physiotherapists use in their practice. So it's almost my last slide. We've gone on to describe how these behavior change techniques are used in one particular setting, in chronic low back pain exercise program. And that program is designed to enhance patient self-management. And at each part of a three-step process, considering patient expectations, determining the importance of treatment outcomes, and designing an exercise program that builds patients' feelings of self-efficacy, we observed the use of behavior change techniques. And the techniques provide feedback, they give reinforcement to the patient, they also use self-monitoring and internal reinforcement, all designed to help the patient become better self-managers. There are a couple other studies we have underway. We're looking at the first encounter of when a patient and a physiotherapist get together and examine. We're looking at different techniques that are being used to help, right from the get-go, help the patients develop good self-management skills. And we're also listening to patients who have been previously prescribed therapeutic exercise and are coming back to rehabilitation, and trying to understand their narrative around perceptions of barriers and facilitators to exercise, to learn, what might some of the best practices be of trying to encourage our patients to exercise when they're in pain. So that's what I prepared to speak to you about. I'm wondering if there are any questions or if I can clarify anything.
So sorry about that. We do have a few questions. One is, how do you work within the often conflicting messages around hurt versus harm? So sometimes you'll get from one, maybe a GP, that if it hurts you shouldn't push through it. Maybe a physical therapist would say, work through some pain, but make sure it's not being harmful. Like, those messages can come from differing places. And how do you work within those conflicting messages?
So my opinion on that is that that's not a simple path to walk. And my view on that language, this notion that it hurts you but it won't harm you, the purpose of using that instruction or helping the patient think that way is to shift their fear of hurting themselves away from, sort of shift their thoughts about being afraid of hurting themselves towards more engaging with activity. But this is it's a difficult path to follow, because of course, if they're in a situation where they're in an acute pain flare-up, then activity is not necessarily going to be extremely helpful. A lot of activity, a little bit of activity, of course, and so there are situations where you actually will cause more damage, right, if you are too active. So it has to come from a place of knowledge on the clinician's part that yes, they are safe to exercise, and then the hurt not harm logic and cognitive restructuring, we call it, is useful, because they can start to feel the discomfort but not start to tense up and avoid the activity. But if you're dealing, part of the question is dealing with what some clinician says, and then you're dealing with the patient saying, well, he said this, and so on. You might try putting it into the context of, well, what, it could have been true at the time that you should be resting at this point, but now we're in a place where you need to be more active. I don't know if that's helpful.
All right, and then someone with chronic pain was asking about how to be consistent with exercise when there is so much pain, and how sometimes it seems easier, but if you have any suggestions for building the consistency piece of being physically active or of exercising.
Okay, thank you for the question. And it's sort of tricky to answer them, out of full context. I'm going to guess at maybe some of the context. One of the philosophies that we have for sure is to set people up. The way I think, or some of the language I use, is set someone up to win. So, and that involves being aware of what the threshold is to creating a flare-up or paying, some people say, like, paying for it the next day. Being totally aware of where your limits are, and as you start to increase your activity level, you undercut cut that. So you never hit the threshold at the very beginning, so that every time that you do engage in some kind of activity, you're successful. And that's to build this whole notion of self-efficacy. Oh, I can, I don't know, walk around the block and it doesn't hurt me. Wow, that's great. Well, the answer from that is not to do it 10 times, but in fact, after a period of time, like say the next day, do the same thing again, so that you're building your confidence, you're building your flexibility, your openness to the exercise, your willingness to engage in it, and encouraging your body to do so, and you're being successful every time. So consistency could reflect, following a schedule, but it also might reflect what a segment of people with chronic pain experience, and this is sort of a boom-bust. They feel pretty good, so they go after it and they do it 10 times, and then they really are flared up for a long period of time, and then they try it again. So the boom-bust style of getting back into activity is really, it can undercut the self-efficacy. Then you feel you can't do anything or whatever. So not going after as high of a goal, but setting your goals as completely achievable, and sticking with them for a while, and noticing that if you keep doing the same thing, that in fact it smooths out a bit and you don't go up and down so much. Again, I don't know if that's helpful, but that's the pacing notion is used quite a lot in returning to activity.
Very good. Someone asking, is there evidence that the connection between expectation and outcome is causative rather than correlative?
Great question, and I'm going to tell you about a book I just finishing reading, and it's about expectancy theory that dates back to actually around the year I was born. So there was a PhD student in California, Rosenthal, who decided he was going to do a little bit more data analysis on the study he was doing, and stumbled over experimenter bias. And that opened an entire field of expectancy theory, which led to ultimately randomized controlled trials, providing control, comparison groups in research, meta-analysis, all kinds of statistical techniques, all from this, extra statistical test he did on his study. And what he did in essence was he looked at the bias that the researcher was bringing to the study. And just to tell you, like a very simple example of the many studies he did after it to prove this effect. There's proof to this. This is one that's sort of in the mythology of research. They had rat studies, right, in psychology labs, where they had, genetically the same rats in two groups. They were exactly the same age. They ate the same food. They had all the same stimulus. And they had two groups of students training these rats on standardized tests. And they told the different two groups, they told them different things. So they said to the one group that the rats were actually genetically malfunctioning, and they were actually slow to learn. They were going to be not going to be able to achieve very much. And the other one, they were normal. And so they went through the testing, and what do you think the results were? The animals actually showed differences in their scores that were predicted by the expectation that the trainer had of the rat, right? So this is a basic science kind of example. It's much harder to prove in adults with low back pain and so on. But there's a very deep and rich literature around expectation, and the other large field which it's completely linked to is the placebo and nocebo effects, where if a patient expects an outcome and they take a non-medicinal, pill, let's say, often that patient will get the effect that the placebo is pretending to be, right? So there are lots of strong evidence of the effect.
All right, and then let's see, someone asking, since pain is often subjective and relative to the individual, how would one be able to approach assessing to determine the level of function and capacity?
Well, I'm not an expert in that, but I do know that you're absolutely right. The definition of pain is essentially, a subjective experience. We can't draw blood and find out how much pain somebody's in, or there's no real objective measure that we can use that says, Catherine's got more pain than Tanya. But and so therefore that's what we do. We use functional measures. We use questionnaires. We use self-report data where we say, yep, it's a 5 out of 10 right now. We use all kinds of things. And we use observation. In fact, there's lots of people who report on, physical displays, facial expressions, coordination of movement. There's books on pain measurement, so to speak, but it's always an indirect measure because, of course, it could be a muscle strength problem that's impairing someone's functional ability. But that's what we're saddled with. We have this really amazingly complicated phenomenon, and it interferes with people's lives, and it gets in the way of making good judgments about certain things. So there is a strong pressure to figure out ways to measure it, but we don't have that. So, and there's also people doing, brain scans and fMRIs, which is an exploding field of research. And once again, it's a physical measure. It's a measure of activation of the brain, but they have to interpret it and say, well, that's because some part of the brain is being processed, and that's where pain is processed. But we don't really know that, right? We don't have any true measure of pain.
All right, and what suggestions do you have for therapists to deal with lower back pain patients who need to have a diagnosis when, in the majority of cases, you can't actually tell them what the exact source of pain is?
Yeah. We were doing an interview this morning with a healthcare provider, and we asked that question in the study I'm doing. Is it helpful? I mean, the evidence I showed you earlier is like the patient is, wants to know what's the diagnosis. So then, okay, that makes this treatment effective or useful, and we can't often put our finger on, especially with low back pain. Non-specific low back pains or mechanical low back pain is like the most common diagnosis, right? And the participant and the interviewer both said something like, "I hate that, I hate that label," and I think it's because it's so unsatisfying to the patient. People want to know what it is that's wrong with them, and they don't trust us to be able to help them if we don't really know what's wrong with them. So so how do we do it? We do what we can to find ways that will alleviate their discomfort, so that they know that we have some knowledge of what we're doing, that will help them. And then, we have to find ways to engage them and figure out that, in fact, exercise or other interventions that they get involved in is the solution, right? And So that's why I try to sort of boil it down into three things that might hook them to engage them, right? Figure out what their expectation is. Many people, their expectation is to get rid of their pain, right? Let's drop the pain. Okay, so we're going to try to work on that. How important is it to you so you look at the importance, and then you look at their confidence in being able to engage in the activity that you are pitching to them as the solution to the solution that you have to offer to what they've brought to you, right? It's not a simple thing, and the diagnosis really is a troubling piece of it.
Wonderful. I think that's a very good answer, and it is so complex and complicated. And then I think a lot of it comes back to, like you were saying, it's hard for the patient to trust when they when they aren't fully sure that you know what's wrong with them.
Yep.
And I think that that building that trust is definitely part of engaging on the issue of exercise and treatments of all kinds. But yeah, it is very, very complex.
Mm-hmm.
All right, I think we are at about time, and the questions seem to have dwindled down as well. So thank you very much, Catherine, for your presentation and for being here with us for this. I think it was very helpful and very insightful.
Good. I'm glad you enjoyed it, and thanks for your participation. I know that it's sort of mostly one way, but at least I got a little bit to know about you. And good luck working with these challenging patients. They need you. They need your help.